Welcome to day 2 of Brain Awareness Week for tonight's webinar on first seizures and epilepsy with Dr. Emma Foster. For those of you who don't know much about the Brain Foundation, I'd just like to briefly introduce us. The Brain Foundation was established in 1970 with the primary goal of funding high-quality Australian research into brain diseases, disorders, and injuries. Secondly, we provide medically reviewed resources about different brain conditions that you can use to learn more about a particular disorder. And lastly, we raise awareness about the impact of brain diseases and advocate for patients. And to showcase a bit more about us and what we do, I'll be highlighting a different project or resource each day throughout Brain Awareness Week. And today I'd like to highlight the Brain Foundation's Research Grants Program, which, as you saw in our mission, is our primary reason for being. So every year we fund research into a wide range of brain diseases, disorders, and injuries. In 2025, this included conditions such as dementia, epilepsy, migraine, and motor neuron disease, just to name a few. Our grants program is specifically intended to support research with clear clinical objectives, whether that's identifying potential treatments, developing new diagnostic tests, or finding ways to improve existing tools and treatments used by doctors currently. A lot of our grant recipients are also clinicians as well as researchers, so their experience with patients informs their research, while their research also contributes towards their clinical expertise. This research is absolutely critical to improve outcomes for people living with brain disorders, and we are so honoured and privileged to be a part of this progress towards a better future. And if you'd like to learn more about the research that we fund, you can visit our website to read the project summaries and also watch interviews with some of our grant recipients. Now I'd like to introduce tonight's speaker, Dr. Emma Foster. Dr. Foster is a consultant neurologist at the Alfred Hospital, Melbourne, with a special interest in epilepsy and headache. In addition to her clinical work, she is an early career researcher at Monash University. She is published in leading international journals, including Lancet Neurology, and is regularly invited to present her research at national conferences. She has been the recipient of several prestigious grants and awards, including 3 Brain Foundation grants, and is a proud national ambassador for the Epilepsy Foundation. Dr. Foster looks forward to contributing to ongoing clinical and research efforts to improve the lives of Australians with brain disorders, and we are so excited to have such a fantastic expert here tonight. And before we get started, just a brief introduction about me. I'm Anik, and I'll be hosting today's webinar. I'm the Programs and Impacts Manager here, and I've worked at the Brain Foundation for almost 6 years. I oversee our research grants program, and I also write a lot of our website and newsletter content. And tonight we also have Vanessa Mundell moderating the chat. You'll see she's just sent a message. So if you have any questions or issues today, just ask in the chat and Vanessa should be able to help. And without any further ado, I will let Dr. Foster start the presentation.
Thanks for joining the webinar tonight. I'm grateful for the Brain Foundation to invite me to speak to you on first seizures and epilepsy. These are my disclosures, so it's research funding to support my research. And I'll be talking on 4 main themes. I'll give you a bit of background about epilepsy and why it's such a globally important condition. I'll discuss diagnosis and how it's made. We'll talk a little bit about the treatments available and also about ways that epilepsy may be prevented. So epilepsy has been around for a very long time. There are stone tablets with descriptions of epileptic seizures chipped into them. And along with epilepsy has come support. The International League Against Epilepsy is the professional worldwide organization for healthcare professionals, scientists, and research looking to support people living with epilepsy. And that's been established in 1909, almost half a century before the World Health Organization was established. Recently, the World Health Organization released this report, the Intersectorial Global Action Plan on Epilepsy, or IGAP, and that's really in recognition of what an important condition epilepsy is globally. And this IGAP focuses on 3 main aims: that 90% of all people with epilepsy are aware of their diagnosis as a treatable brain disorder, that 80% of people with epilepsy have access to appropriate, affordable, safe anti-seizure medication, and that 70% of people with epilepsy on treatment achieve adequate seizure control. And around the world, groups are forming, including in Australia, with key stakeholders, so epilepsy advocacy agencies, people with epilepsy, researchers, scientists, healthcare professionals, to work at a local level to do what can be done to achieve these goals. So focusing in on Australia, we know that over 250,000 Australians live with epilepsy. It affects people of all ages, sexes, races, and it's the commonest brain disorder across all ages. People often think of epilepsy as a brain condition of childhood, and that makes sense because you can see here, before the age of 5, there's a very high incidence of new diagnosis for seizures and epilepsy. It then drops off in a U shape, but never nothing. And this is consistently seen that we will see people of all ages with first seizures and new diagnosis epilepsy. But you can clearly see after the age of 60, there's a big uptick in the number of people who experience first seizures and new onset epilepsy. And if you're an adult who develops epilepsy, the time you're most likely to do so is after the age of 65. So in our society, epilepsy is also a condition of older adults. Now, this is a busy schema, but it's the structure in which healthcare professionals and researchers and scientists approach epilepsy. We start from a clinical perspective when we see someone with a possible seizures to investigate whether it was an epileptic seizure, and if yes, did it come from one area of the brain? So was it a focal onset seizure, or was it generalized onset, which means it started around the brain at the same time? If it was a seizure, then the next question is whether it is epilepsy, because seizures and epilepsy are not the same thing. More on that later. And what type of epilepsy is it? We then move across to the etiology. So epilepsy probably should be called epilepsies because it's a whole group of conditions that all are similar in that they cause people to have unprovoked seizures. But the underlying cause can be radically different, and that can influence the onset of the epilepsy and the likely progress going forward. So an example of a structural cause of epilepsy could be an old stroke. An infectious cause of epilepsy could be from an encephalitis. It's then also very important to consider comorbidities. What that means is other medical problems that might accompany that epilepsy. We know for sure that there are certain health conditions that are more likely to occur in people with epilepsy. And sometimes those health conditions can drive epilepsy, and sometimes epilepsy can drive those health conditions. And so it's important to step out and look at the whole person and really make sure that they are cared for, often by a multidisciplinary team. So a seizure is a burst of electrical activity, and that describes the event itself. Epilepsy is a condition characterized by recurrent, unprovoked seizures, but also the neurobiologic and social consequences of that condition. So the diagnosis is a clinical diagnosis. That means it's made on the description or the eyewitness event itself. There's no single test by itself that can diagnose epilepsy. We always need to have evidence of having had a seizure as well. But this can be difficult. In general, people think about the big seizures, the convulsive seizures, where people fall to the ground and have a fit, they shake, they go stiff, they might froth at the mouth. But there are many seizures that don't come across like that. The way a seizure looks will depend on where it starts in the brain or what area of the brain it affects. Seizures that start in the frontal lobe, for example, often occur when people are asleep and involve vigorous movements of arms and legs. Seizures that happen from the temporal lobe, which is about here, can be experienced by people as intense, intrusive déjà vu, which is this feeling that they've almost been there before. They can almost remember what's going to happen next. It's almost like they're remembering a dream. And seizures that occur in the back of the head in the occipital lobe, where the vision is processed, can come across as colored shapes in a person's vision. So because there are so many ways a seizure can look, we have to think about other ways to tell what they are. Most seizures are very short, less than 30 seconds duration. Seizures will be stereotyped. If a seizure comes from the same part of the brain each time, the seizure will look the same each time. And surprise, that means that seizures will be unpredictable. They can occur when people are awake, when they're asleep, in the morning, in the evening, when they're eating, when they're resting, when they're exercising. So we take those three elements, the three S's, and see if it applies to the event that the person comes with to assess whether it's a possibility it may be a seizure. Oftentimes, seizures will impair a person's awareness, and so they may have very limited recall about what actually happened. And so in addition to getting the story from the person who experienced the event, it's really helpful to have eyewitness accounts. And often people will have seizures that are seen by friends or family or work colleagues, and they bring that person in to the clinic session with them. Now we've got smartphone video and CCTV. We often can also get a recording of the event with the person's permission and watch that in clinic, and that can be very informative to help us assess what the event was likely to be. Now, once an event has been found to be a high probability or definitely a seizure, the next step of the algorithm is to work out, does this person have epilepsy? There's three main ways we diagnose epilepsy. The first way is identifying 2 or more unprovoked seizures more than 24 hours apart. In my clinic, I work in a first seizure clinic. It's common for me to see someone once they have a big convulsive seizure, which is obviously, for a lot of people, it's an obvious recognition of a seizure. And then when we talk through what's been happening in the last few weeks or months or even years, people will describe short, stereotyped surprise events that lead for a diagnosis of epilepsy. Sometimes we recognize an epilepsy syndrome, so that's a very specific presentation of epilepsy, like juvenile myoclonic epilepsy, that comes along with a very recognizable signature on the brainwave test. And the most recent way that's been described for diagnosing epilepsy is identifying at least one unprovoked seizure and recognizing something else in that person's body that puts them at greater than 60% chance of seizure recurrence. So if we dive into that a little more and we look at what actually constitutes more than 60% chance, this information comes from big data across multiple countries. An EEG is a brainwave test, and there are particular brainwave shapes that make us know this person's at a greater than 60% chance of further seizures after having had one seizure. We've got high-resolution brain scans now, like MRI scans, but even CT scans can be helpful to look at evidence of old strokes, infection, trauma, or bleeds that can leave scar tissue on the brain, and that can lead to the development of epilepsy and also identifying tumors. We're getting emerging research that shows people with first seizures happening during sleep are at a high risk of more seizures occurring. And also, if people have seizures who are living with dementia, are also more likely to have ongoing seizures in the future. And so when people pass the 60% risk threshold, that's a time when we diagnose epilepsy and discuss treatment. Now, once the epilepsy is diagnosed, we take that step back and look at the overall person for any other conditions they might have. This is a study published from the United Kingdom of 10,500 adults with new onset epilepsy. And the researchers looked at all the other medical conditions these people had. And they found that people fit very neatly into one of four categories. The first category, the researchers called the young and healthy. The people had a median age of 44 years. They had a higher incidence of non-brain cancer compared to the general population. Otherwise, were fairly similar. The next group, the researchers called the cancer group. Average age was 52 years and a higher amount of brain cancer and non-brain cancer compared to the general population. The next group, the researchers called older with chronic disease. Now, in general terms, chronic can mean something that's intense or severe or bad. In medical terms, the word chronic means something that's just been around for some time. And this group, the older with chronic disease, had an average age of 71. And they had a much higher incidence of angina, heart failure, irregular heart rhythm, atrial fibrillation, heart attacks, high blood pressure, diabetes, high cholesterol, and stroke. And so in this group, you can see there's a link there between brain health and heart health. And we'll discuss that further down when we talk about preventing epilepsy. The final of the four groups that the researchers recognized was a group they call the psychiatric disease group. This was a group of new adults with new onset epilepsy, average age of 45, and a high amount of alcohol misuse, smoking, recreational drug use, anxiety, and depression. And so knowing these various categories can be very helpful when you see someone with new onset epilepsy to think about what else is going on. Some of these factors will have a bidirectional relationship with epilepsy. So epilepsy makes the other condition worse, the condition makes epilepsy worse, and it's important to treat all of that together. So for treatment, these are the four aims. We aim to get people seizure-free with minimal side effects. 2 in 3 people can become seizure-free on medication, and the majority become seizure-free on just the one treatment. People are classified as having drug-resistant epilepsy if they continue having seizures even after having 2 good trials of anti-seizure medication. And for people with drug-resistant epilepsy, it's really important to have them referred early to specialist care. In a comprehensive epilepsy center, people may be offered epilepsy surgery, neuromodulation, and diet. So anti-seizure medication is the main way that we treat epilepsy. This is a chart that shows that over time there's been a rapid increase in the number of anti-seizure medications available. They all work in slightly different ways and they have different side effect profiles. Anti-seizure medications at this stage aren't showing themselves to be anti-epileptic, although more study is underway at this time. An anti-epileptic drug would be one that reverses the underlying epilepsy tendency. Currently, it seems most of our anti-seizure medications make it harder for a seizure to break through, but can't fundamentally change the underlying epilepsy tissue. The medication that is chosen with a person will depend on their age, their sex, their epilepsy type, so focal or generalized is the usual dichotomy there, the side effect profile. So for example, some anti-seizure medications can make people gain weight or lose weight. Some anti-seizure medications are actually useful for other conditions. It's like a positive side effect. So for example, a lot of people with epilepsy also have migraine, and a lot of the anti-seizure medication are migraine preventers. So you could prescribe one medication for 2 conditions. We need to be mindful about drug-drug interactions, particularly older anti-seizure medications like phenytoin, which was developed in the late 1930s. Its medication level in the bloodstream can be greatly altered depending on what other medication people are on. Cost is really important. There's roughly 21 anti-seizure medications on the PBS, but not everyone can access them immediately. Often you have to trial several medications before you can access a particular anti-seizure medication. Cost is really important. These anti-seizure medications are often needed twice daily, every day for years. And teratogenicity, which means that whether anti-seizure medications can harm a growing a baby, is important to be aware of as well. Some medications are safer than others in that instance. Education, along with anti-seizure medication, is critical to making sure that we can keep people safe and well. Common precipitants for seizures. So someone has epilepsy and they find that seizures are more likely to happen if they are stressed. Stress can be cognitive stress, mental stress, also physical stress, like if they're unwell, tiredness or sleep deprivation, alcohol. There are other precipitants that will vary for individuals. It's important that driving is addressed. There are driving restrictions in place for people who've had seizures and epilepsy. And it's important to talk about safety around water, at heights, and people might have specific jobs where it's important to consider seizure safety. There's a lot of really great epilepsy advocacy agencies in Australia. Here are some large national groups, including Brain Foundation, Epilepsy Action Australia, Epilepsy Foundation, and Australian Women with Epilepsy. And there may also be local groups in your area that can provide really important education and support. There's also some expert guidelines on things like epilepsy and sport. Australia is a pretty sporty nation. So this is the International League Against Epilepsy that I introduced earlier in the talk, and their expert recommendations regarding seizures in sports. Obviously, every part of the lifestyle modifications need to be tailored for the individual. Risks and benefits need to be weighed up for that particular person. So this study looks at data from Scotland, but was actually published by an Australian group. And they looked at the outcomes of people with newly diagnosed epilepsy. They found that just under half of people remained seizure-free on their first anti-seizure medication, and 2/3 of people were seizure-free at some point, but for some people they needed to trial many medications before they got there. But there was a group of people consistently who remained, unfortunately, with seizures despite trialing many anti-seizure medications. So that's the group with drug-resistant epilepsy. So for this group, advanced therapies should be considered early. Surgery is one of the advanced therapies. Typically, epilepsy surgery, which is brain surgery, will involve a person having a lot of admissions to hospital, testing and retesting EEGs to provoke seizures, confirm where the seizures are coming from, neuroimaging to look at whether there's any obvious scar tissue or little abnormality on the brain that is likely to be driving the epilepsy. And candidates are selected very carefully, weighing up again the risks and the benefits. And 50 to 60% of suitable epilepsy surgery candidates can become seizure-free and with a low mortality and morbidity. Neuromodulation is like a pacemaker for the brain. So devices include vagus nerve stimulation and deep brain stimulation. Basically, a person will have like a battery pack just under their skin and little wires running under their skin, either up to the vagus nerve for the vagus nerve stimulation or into the deep brain for the deep brain stimulation. And those generate little pulses that settle seizure activity. And clinical trials show that can be very effective at reducing seizures, particularly in the short term. The data is lower quality in the long term, but the signals that we're getting is that it's still very effective. And then there's the modified ketogenic diet. This is typically a diet prescribed for a particular person by a clinical dietitian who has expertise in epilepsy management. the dietitian will sit with the person, talk about their typical day, who they live with, their dietary preferences, allergies, and work out a plan for a diet that is very low in carbohydrate, high in fat, and high in protein. And of this group of people who have ketogenic diet, so remember this is a group with drug-resistant epilepsy who have still had seizures despite trialing at least 2 anti-seizure medication, 10% can become seizure-free with a ketogenic diet. And the majority, 60%, have a greater than 50% seizure reduction. These diets can be challenging to adhere to. They can be socially difficult. And so there is 30 to 50% discontinuation in 3 to 6 months. Now, epilepsy prevention. There is a great webinar that's happening this week as well as part of Brain Awareness Week on brain health. And so I'd encourage you to check that out. But essentially for epilepsy, we need to remember that heart health is brain health. We remember from that study in the UK with the 10,500 adults with new onset epilepsy, there was that group called older with chronic disorders. And you could see many of those disorders were heart disorders. And so it's important to keep active, to have good social networks, a healthy balanced diet, particularly the Mediterranean diet, which is high in leafy green vegetables, multigrains, and low in saturated fats. Get adequate sleep and rest, to have good literacy and treat depression and anxiety. These are all critical factors to help keeping a whole person well, which will help keep the brain well and healthy as well. This goes well beyond what can be prescribed in a doctor's office and really involves many different moving parts to help support the community's health. And this is one part of looking at epilepsy prevention. Epilepsy obviously has many different causes, and there'll be needing to be many targeted strategies. For example, reducing the risk of trauma, brain bleeds, and stroke are also other major ways that we can address brain health and reduce the chance of epilepsy. And then the ultimate goal from my point of view is really to find a way to reverse epileptogenesis. So whatever the cause of the epilepsy, there's some common pathway that leads people to have a brain that has recurrent unprovoked seizures. And so to truly remove epilepsy, we need a way to reverse this process. And there's research all around the world underway at the moment. And this is a shout out to the Brain Foundation that does a great job supporting brain research, including 13 epilepsy grants in the last 10 years. So with that, thank you very much. And I look forward to your questions.
Thank you. That was such a fantastic presentation, and I'm really looking forward to going through the questions that have been submitted so far. If you haven't submitted your question yet, we'll keep refreshing it, so please feel free to submit it now and to make sure you vote for the ones that you want us to prioritize in the Q&A session. But let's get started. The first question that we have is from Linda, and she has asked if you can please discuss absence seizures.
Yeah, absolutely. So thank you so much again, Anik, for hosting this wonderful event with the Brain Foundation, and thanks everyone for logging in and for your great questions coming through. Just as a reminder, I can't give any personalized medical advice, but we'll be speaking in more general terms about these really great questions. So absence seizures. Absence seizures often come as part of childhood epilepsy, and they're called absence seizures because when a person is watching someone with an absent seizure, that person with the seizure kind of gets a bit of an absent look about them. So often they pause what they're doing. The absent seizure often doesn't last long at all, and so it's not uncommon for absent seizures to go unnoticed for months or even years. And the person will pause just for a few seconds and then continue with what they're doing. So, for example, if it's a child in primary school, they might pause colouring in for a few seconds, then it passes, and then they go back to the activity. I'm an adult epilepsy specialist, so I come from hearing the perspectives of young adults, often who come in with the absent seizures. So one patient described to me when he had a seizure, he was actually holding a remote control for the air conditioner and he was changing the temperature on it. So he's pressing the button and he wanted to get up, I think, to 25 and it was on 19. So he's looking 19, 20, 21, 26. It was like, oh, that's really weird. And he realized he had had a seizure. It just was a few seconds. He was still continuing the activity that he was doing, but he had sort of disconnected with that. So that's what an absent seizure is. It involves seizure activity over the whole brain when it happens. And any seizure that involves seizure activity over both parts of the brain impairs people's consciousness or awareness.
Great, that was a fantastic explanation, Dr. Foster. The next question that we have is about infections and seizures. Specifically, what types of infections can cause seizures, and can an ear infection, for example, cause seizures?
Great question. So I think to answer that question, it's good to take a step back. What I didn't include in my talk was actually seizures that are not epilepsy. A brain that has an insult, whether that is a low blood sugar, a low sodium level, a bad infection, a trauma like a hit on the head, a bleed, a brain can have a seizure when it is under pressure like that. That is called an acute symptomatic seizure. Around the world, we have a general understanding of different things that can trigger these acute symptomatic seizures. But the general thought is that these seizures are likely to stop when the insult has stopped. So, for example, if someone is having a seizure because they've got a very low sodium level, the understanding is when that sodium level is corrected back to a normal range, the seizures will stop as well. So that's an acute symptomatic seizure. So in the context of encephalitis, which is an infection that affects the brain tissue, the brain is inflamed and swollen, and at that time a seizure can happen because there's an acute insult happening to the brain. Later, what can happen is that brain infection can actually cause scar tissue on the brain. That scar tissue persists, and well after the infection has been cleared, that scar tissue will be there. And in the future, months or years down the track, people can actually start developing epilepsy around that scar tissue because that's an abnormality on the brain. So in that way, a brain infection can cause both the acute symptomatic seizure at the very time of the infection, but later down the track can, because of the scarring, lead to developing epilepsy. Now, the question about are other infections able to cause seizures? It depends. So I think ear infection was put up as one of the examples there. Every human has got a different threshold when they'll have a seizure. So some people, for example, playing a football match, might be struck on the head. They feel a bit concussed. Nothing happens. Other people get struck on the head and they have a seizure from it. So it's all about what natural seizure threshold you have. So depending on what your seizure threshold is, if you're extremely unwell with an infection, you have high fevers, it's possible you have a seizure in that context. I hope it sort of will be very individualized and hard to predict and say which infection can cause a seizure, but that's a possibility, particularly people who do live with epilepsy, which by definition just means a higher tendency to have the breakthrough seizures. If they're unwell and they have high temperatures and fevers, might be more likely to have a breakthrough seizure at that point.
Great, thank you. The next question that we have is from Mandy, and she's asked if you can please expand a little more on the seizures where a person has colored shapes in their vision.
Yeah, absolutely. So a seizure generally causes or a seizure basically stimulates areas of the brain, and depending on where that seizure is occurring, that can be what causes the symptoms that people feel. So your brain has different areas that control different activities. The occipital lobe, which is in the back of the head, is where a lot of the visual input is processed. So what you see gets fed into your brain, and your brain does a lot of analysis before it tells you what it is you saw and how that relates to your world and your environment. So if a seizure arises in the occipital lobe, say someone has a lesion there or scar tissue there, it can actually cause people to see shapes, like colored shapes, or a visual change in front of their eyes. It's a rarer type of epilepsy.
Mm-hmm. Yeah. Thank you. The next question that we have is about the Senate Enquiry for epilepsy in Australia. And with this inquiry, is there something that you would like to see come in as a recommendation that would help people with epilepsy to a high level?
So I'm really glad that there's this inquiry. It's really important. I hope it does a lot in terms of raising awareness and making meaningful change to people living with epilepsy. From a researcher's perspective, I think it would be important to get more funding for research, but I think the most important aspect of these inquiries is to bring in the patient's lived experience and understand from the lived experience perspective, what is it that can be done and known by society to improve and support people's lives who live with epilepsy.
Mm. Yeah, fantastic. Yeah, it's definitely so important, and the potential of these inquiries is huge. So hopefully we see it realized. The next question that we have is what are ways in which you can determine the extent of brain damage or injury as a result of epileptic seizures? Is it something that you can request from your doctor or healthcare provider?
That's a good question. I don't think there's a single test really that we can run. Certainly, when people are being diagnosed with epilepsy, we do a brainwave test, and we can do several, sometimes increasing duration, to see if we can find the brainwave where the epilepsy comes from. And if people are having breakthrough seizures later down the track, or new symptoms that we haven't seen before, we'll often repeat that to try and get an understanding if it's related to the epilepsy. And we also do neuroimaging. MRI, or magnetic resonance imaging, is sort of the most detailed imaging that we can do on the brain to see any structural changes. So we're looking, in the case of new onset seizures, for lesions, scar tissues, brain tumors, aneurysms, that sort of thing. And again, if someone's state changes over the course of time, we could repeat that. And sometimes people do have seizures that are resistant to medications, and that's when we might repeat it as well. Sometimes when we do more than one scan, the second scan picks up things that we didn't see in the first scan, and that's to do with the scanner and the sensitivity of it. I hope that sort of answers around that question there.
Yeah, that's fantastic. Thank you. The next question is about stroke, and they've asked, earlier you mentioned that stroke can leave damage that results in the development of epilepsy. And I guess this relates to what we just talked about, but when looking at the brain, what might be some hallmark features that indicate that damage by stroke has occurred?
Absolutely. So as a quick background for people who don't know, stroke is a sudden disruption in the supply of oxygen to brain tissue. Brain tissue is very sensitive to a lack of oxygen and starts dying off quickly. So if you have sudden death of brain tissue, that's called a stroke. You can have a loss of oxygen to the brain tissue in two main ways. The first one is that you get a clot in one of the blood vessels that go up to the brain, and beyond the blood vessel clot area, that brain starts dying off because it's not getting the blood. The second type of stroke you can have is a bleed called a hemorrhage. And so basically a blood vessel will split, and then you do have blood going to some part of the brain, but beyond that, where the vessel no longer is kind of connected to the rest of the rest of the arterial system, you're not getting the blood going there, and so the tissue beyond that breakage begins to die off. So the symptoms of a stroke will again depend on which area of the brain is affected by the stroke. We often think about the FAST acronym. So you look for a facial droop, you ask someone to hold their arm in the air, you ask someone to speak, and if you realize something has suddenly happened to a person and they have a facial droop, or they can't lift their arm, or they're having slurred speech, time, that's the T of FAST, is critical. You've got to call an ambulance, 000, and get them straight to a hospital, because there are medicines that can help reverse the clot. And there's other options as well to try and get on top of that. So that's how you can find out if there's been damage from stroke. Depending on the size of the stroke and rehabilitation, people sometimes regain some function or a lot of function. Sometimes people don't regain a lot of function. And post-stroke epilepsy is an important complication that can occur. With stroke, there's some permanent damage on the brain, and that damaged tissue becomes scar tissue over time, and that then can cause seizures in the long run.
That was a fantastic explanation, Dr. Foster. Thank you. I've also just noticed that there's some discussion and some people have shared links for the parliamentary inquiry in the chat. We will be sending out an email after this webinar with the slides and links to a few resources. So we'll make sure to pop that link about the inquiry in that email as well. But anyway, moving on with the questions, we've got lots to address here. The next question that we have is from Laura, and she's asked if you can please shed some more light on why individuals with intellectual disabilities are more likely to have epilepsy than the general population.
That's a great question. And there are, this isn't for all cases, but we certainly have identified some genetic links that underlie intellectual disability, epilepsy, and also autism spectrum disorder. So sometimes you do see these diagnoses and combinations together.
Mm-hmm. Okay. Is there more investigation happening in that space? What's the, I guess, like future outlook in that area?
It's a great question. So there's a lot of work in this space. There's a lot of very dedicated patient advocates and researchers. We are very lucky in Australia, actually. We've got a very strong pediatric epilepsy research and clinical program where our researchers in Melbourne actually have identified various genes. So there's a lot of work in that area in terms of increasing the speed of diagnosis, because often when there's an answer, that's a big step towards helping with the next phase and planning and getting support around people as well. And there is ongoing work at developing new medications for some people who do have sort of the genetic epilepsies. They can be more resistant to traditional medications. So there's a lot of work in drug development for other medications that are more effective in people with this.
That's great to know, and it's always so exciting to see when we're kind of on the precipice of, these new discoveries, which are, I guess always happening in this space. The next question that we have is, how does epilepsy or seizure affect sleep? I understand that poor sleep can trigger seizures. Can you explain that link?
Yeah, that's a great question. And we know that there is certainly a connection with epilepsy and the circadian rhythm. The circadian rhythm is the day and night cycle that we all have. If you've traveled overseas, you might have experienced jet lag, and that's sort of a mismatch in the circadian rhythm as you're trying to readjust to, for example, if you go to the Northern Hemisphere, often your day becomes night, your night becomes day. And we know that there are particular epilepsies that definitely link in with sleep cycles. For example, there's a type of epilepsy called frontal lobe epilepsy, where commonly people will have seizures in the first few hours after they've fallen asleep, when they hit a particular sleep cycle with the brain waves. And there's other seizures types as well that happen quite commonly at very particular times of the day. So there's clearly a link with the circadian cycle and seizures in a lot of cases. We know that if you haven't rested well, people with epilepsy, and particularly there are particular types of epilepsies like the idiopathic generalized epilepsy or IGE, which often happens in younger people. That's often very sensitive to sleep deprivation as well. And it's probably to do with this disruption of the sleep-wake cycle. This is a really interesting area. There's a lot more exploration and research going in. So I look forward to maybe updating you all in a little while as we learn more about it.
Well, we look forward to it. The next question that we have is from Nikki, and she's asked, why do seizures suddenly start occurring for some adolescents when they haven't had them occur during childhood as a response to any particular triggers?
What a great question. And look, this is often a question that we have in the first seizure clinic with people who've been well and haven't really had anything particular happen, and then they suddenly start developing seizures. I think epilepsy, like a lot of conditions, will be down to a bit of a combination of genetics and environmental triggers. And often the genetic contributions are very minor and across many, many, many genes. So it's very hard to say which particular thing has caused it. And likewise with environmental triggers as well. We know epilepsy is unprovoked seizures. Sometimes there are obvious triggers for particular people. Sometimes there's not one. And it might, again, just be a particularly unique combination of very small things that individually don't make you cross a seizure threshold, but in combination do.
Great, that was a good explanation. Thank you. The next question is from someone who has asked, what's the most valuable information we could provide as an observer of someone having a seizure?
That's also a great question, and certainly having an observer's input during a consultation with permission of the patient, of course, can be incredibly valuable. So often if people are having a seizure, they have a degree of impaired awareness. They can't quite tell or recall everything that goes on. And so having that extra person watching and reporting what's happened has been incredibly helpful. So in terms of what we would ask, the first thing is always safety. So if you see someone having a seizure, the first thing is to make sure you feel safe and they're safe as well. So just a quick moment on seizure first aid is to push away furniture so people don't hurt themselves on it. Help roll people onto their side. We call that the recovery position. Make sure you do not put anything in their mouth. And I say that because a long while ago, that was actually what was recommended. But we know that if you put fingers or spoons or anything else in their mouth, there's a big risk that they will injure themselves, teeth get broken, and that mouth trauma can cause much more, a lot of problems. So that's seizure first aid. So if you witness a seizure, just the basics of what to do. If a seizure goes for more than a few minutes, please call an ambulance, 000, and always call an ambulance if you're ever unsure or don't feel comfortable with what's happening. Also, if someone doesn't regain consciousness within a few minutes after their seizure, consider calling an ambulance as well. Have a low threshold to call an ambulance. So what to report? So I just want to recognize that it is rather traumatizing and can be very confronting seeing a seizure. But if you're up to it and you feel safe and the person that's having a seizure is safe, see if you can interact with them, see if you can talk to them, if they can respond. We would like to know, are they responding a bit slower than usual? Are they maybe pausing and not responding at all? Is what they're saying make sense? See if you can do some interactions with them. So a tap on the shoulder or maybe ask them to raise an arm. Again, are they responding? Are they following instructions or not? We'd like to know if they change color in their face. The reason is that seizures can often look a lot like other things. And sometimes if there's an arrhythmia or a heart rhythm problem, that can also sometimes come across a little bit looking like a seizure. So it's helpful to know if their face changes color. Are their eyes opened or closed? Do they froth at the mouth? Have they got blood in their mouth? So sometimes seizures make people clench their teeth and they bite their tongue and then or cheek, and it can cause a bit of blood there. What movements are they doing? Are the movements sort of big, stiff, jerking movements? Do they wax and wane? Does the person seem to be able to semi-respond to you, even though their body is doing an involuntary motion? I think they're sort of the key things. And after the seizure finishes, is the person exhausted, drained? Are they maybe a little bit confused for a little while as well? Yep.
That was great, very important practical information to for people to know, for sure. The next question that we have is from Adela, asking about saying that they talk about the connection between temporal lobe epilepsy and the amygdala. Does each side amygdala do different things, or can one side take over for both, like with kidneys, if one isn't working or if it's removed?
That's a good question. So just a little bit of neuroanatomy. Your temporal lobes are in the, your temple is about here. So your temporal lobe is sort of just behind that bone on each side. And your temporal lobe does a lot of jobs, and memory is one of the big jobs that it does. Deep to the temporal lobe is the amygdala, which is a part there. And its main function is sort of in the fear response or the threat detection. Generally speaking, there may be some slight differences between them in terms of how they function. It's an important lobe in epilepsy, because often people who do have temporal lobe epilepsy who have not responded to 2 or more medications can respond quite well to surgery where there is resection or they remove the bit of tissue that is abnormal. In terms of whether it would take over function, this is a really important question. Generally, before surgery, people have extensive workup. They often come many times to the hospital. They're admitted for days or a week or more at a time. Their seizures are caught with the EEG running, the video running. There's neuropsychology who does extensive cognitive testing to work out the different lobes of the brain, how they're functioning, to see if the amygdala or the temporal lobe, whichever other area of the brain lobe is involved and to what degree. And then there's a case discussion with neurosurgeons, neurologists, neuropsychologists, neuroradiologists to talk about how and surgery might, if a surgery is appropriate, and if yes, what would be the risks and benefits, what would be the anticipated potential loss if a bit of brain tissue was resected. So it's all carefully weighed and balanced, and a decision is made with the person. And often people want to take a little bit of time about those decisions. And so to circle back to the amygdala question, that would be part of what would be discussed if the amygdala was part of the area that was involved in epilepsy.
Mm-hmm. Great, thank you. The next question is about epilepsy and hormones, including perimenopause, which seems to be increasing in community awareness. And is there more research going into this area around epilepsy and hormones?
There is research ongoing, and certainly that's a great point. There definitely is recognition about seizure tendency, particularly around particular parts of the menstrual cycle and around the perimenopausal period. It's an space I think that probably could do with a little bit more research as well.
Mm-hmm. It's often the story, I feel, with a lot of these, women's health has been, it's more new, I guess, in the research space, unfortunately. The next question, just saw the time. We'll try and get through a few more before we hit 8 p.m. The next question is from Linda, asking if vomiting after a seizure is common.
Yeah, it can happen. Sometimes even vomiting happens at the start of the seizure, and it's to do with the seizure activating like the vomit center as well. So it can certainly happen.
Mm-hmm. Great, thank you. The next question is, can you please shed some light on the causes of hyponatremia and encephalitis, as they can cause seizures?
Absolutely. So, great question. And those are really good examples of conditions that are recognized as causing acute symptomatic seizures. So, ever so slightly different to epilepsy. So, those two conditions happening so when a person is experiencing it at the time, they can have seizures because the brain is reacting to a big disruption in its environment. So, hyponatremia is low salt levels. You have to have quite low salt levels to trigger seizures, but we certainly see that, particularly if people are very unwell. Encephalitis is that infection of the brain tissue causing inflammation and swelling, and that can trigger seizures. And as we also said, which complicates things a little later, is that when the encephalitis has settled down, there might be scar tissue left on the brain, and in time, months or years later, seizures can arise from that.
Mm-hmm. Great, thank you. The next question that we have is if someone had a seizure induced by drugs or illicit drugs, are they more likely to experience a drug-induced seizure again with the same class of recreational drug? Or is that a one-off occurrence?
It's a very great question. So, this is seen a lot in my first seizure clinic, because as the name implies, the clinic is for people with first seizures. And so we do see a lot of people who've had a recreational substance and they've had a seizure. Oftentimes, they have used that substance before and there's been no seizures, but for whatever reason, this time around there was. There is fresh data out from West Australia. So in Perth, there's a group of first seizure doctors who do fantastic research. They published this just a few months ago, answering this exact question. So they found that they looked at a group of people who had come to their clinic with acute symptomatic seizures. About a quarter of those people had had a seizure in connection with using a recreational substance. They found that the chance of having another seizure in the following 2 years was about 1 in 3, or 28. Sorry, my maths isn't strong. 1 in 3 to 1 in 4, about 28%, which is a lot higher than the general population for having a seizure, but lower than if they had an unprovoked seizure. For reference, if you have an unprovoked seizure, your risk of another seizure is around 40%. So it's absolutely a possibility again. Yeah.
Mm-hmm. Great, thank you. We'll try and get one more in before 8 p.m. We've got one from Virginia asking, she's interested in a general sense of what legacy a seizure might have on a person's brain. And does epilepsy essentially cause lasting effects upon brain health, or can that, I guess, lessen or be remedied in time?
Really good question, and a difficult one to answer. And one of the reasons is because of the different causes of epilepsy. It's very varied. And if your etiology or the cause of your epilepsy, for example, might be a strong genetic cause, that genetic or gene might also be driving other changes. If you've got a stroke and you have epilepsy because of that stroke, we know that underlying stroke and epilepsy risk is also cardiovascular risk. So we remember the slide earlier from the UK study where they found that group of older adults with all the cardiovascular risk factors, blood pressure, high cholesterol, they were significantly high in the epilepsy group compared to age-matched controls. But we also know that high blood pressure, high cholesterol, cardiovascular risk factors underlines dementia, which can drive problems with brain health. So the answer to that question is that it will depend on what the etiology is of the epilepsy, if that's sort of shared risk factors for other reasons for brain health, to drop off as well. Certainly from an epilepsy treatment point of view, we try and get on seizures. That's the central goal, right? Is to try and reduce the seizures or stop them completely, for all kinds of reasons, quality of life, safety.
Mm. Wonderful. Well, that's a fantastic note to end on. Thank you so much again for your time, Dr. Foster, and all your expertise. It was so great to learn from you and to get so many questions from the community answered. For everyone who's been here today, we hope to see you in the rest of the webinars this week. Tomorrow night is on brain aneurysms, so we hope to see you there. And yeah, we will send out the resources after the presentation ends. Thank you so much, everyone, for being here.
Thanks, everyone. Have a good night.